So let's talk about the small pupil heart cataracts. So you are in double trouble because you have a small pupil as well as a hard brown cataract as well. These are the various scenarios wherein you can have. It's very common, not uncommon in a country like India. So what is the biggest problem? Is the biggest problem is the hard brown cataract, the posterior polar cataract, subluxated, or the pseudo exfoliation. The biggest problem is the small pupil. Why? Because in small pupil you are not able to see well, and that is the reason why you are not able to operate well, and that's the reason for all the complications as well. So, because the pupil is small, and that's so you need to make sure that the pupil is well dilated, especially when you are dealing with cataracts like the supra hard cataracts. We call it the cataract rubra or the cataract niagara. Okay, and small pupils can be because of long-term use of myotics, pseudoexfoliation, prior iritis with cyanic A, trauma, diabetes, and improper mydriatic application as well. It's also associated with advanced age, advanced nuclear sclerosis. Use of anti-prostate agents, alpha and tamsulosin, can produce small pupil. Please understand, go through the history is very, very important. Okay, ask for the patient because many patients, even physicians, may not know that tamsulosin can cause a problem like IFIS, which can lead to a severe problem. There is the intraoperative floppy iris associated with the use of alpha 1 antagonist, tamsulosin, or Urimax, lack of tone of the dilated muscles of the iris, a triad of intraoperative signs, iris billowing and floppiness, iris prolapse, progressive miosis of the pupil. So, as you are operating, initially the pupil may be 6 millimeter, progressively it will become 3 millimeter, and you are in trouble at that time. You can stop myotics 48 hours prior to the surgery, long acting, but all these may not work as well. And you need to use what is called the soft cell technique, which has been developed, popularized by Steve Urshinoff, wherein you put viscoat, that is a dispersive viscoat elastic, which coats the endothelium, and then you put hyalon underneath that so that it expands the pupil and also protects the endothelium, especially in brown cataracts. Pupil expanding devices like iris hooks or the rings you can use. And these are some of these challenging situations. You can see here, many of these cases, you can say, sometimes they have cyanic A. You can open up the cyanic A. And even if you don't have access to any of these rings, you can even stretch the pupil. Only thing is the problem is stretching don't stretch the pupil in the axis of the incision because the stretching can cause permanent damage and atony of the sphincter as well. You can see that many of these cases of complicated cataracts, small pupils, there is a small membrane which is not visible on the slit lamp but is visible under the microscope. Once you remove the membrane, you can see how the pupil starts dilating as well. So the fibrous pupillary membrane, you can see here, this is a complicated cataract, post silicone oil vitrectomy, and you can see here how the membrane, once you remove the membrane, you can use small forceps or scissors or vitreous scissors to cut these membranes, go through the side ports, and use good viscoelastic, and you can see fairly good dilatation as well. So pupil stretching can be done. You can use iris hooks, pupil expansion, whatever you are comfortable. Intracameral phenocaine is available, phenocaine plus is available, the ultra is available. So many companies, I don't have any financial interest. It's a combination of preservative-free tropicamide, phenylephrine, and proparacaine as well. So that can also dilate the pupil to a certain extent, but many of these small pupils are rigid, so very difficult. You can see here how I'm putting the patient to pseudo exfoliation, a dense brown cataract as well. When you're putting the iris hooks, it's a very easy technique. Only thing is you make sure that you put the stab incision at the limbus and not in the cornea. Okay, and make sure that you elevate the iris, putting some viscoelastic underneath the iris, and so that it's easier for you to put. If you put it in the cornea incisions, the whole iris will start tenting up, and this can be a major issue. And going in and coming out of the iris, coming out of the pupil, the main incision with the phaco probe, the iris can start coming out. You can see how easy it is because once you do that, and you can stain the anterior capsule in a brown cataract, it's always better to stain because you know exactly where your rhexis margin is and when you're doing the chopping. So just to show you another patient, the pseudo exfoliation, you can put adrenaline in the BSS But consider patient with a mature cataract, very hard cataract. Blurex is very important, not only in mature cataracts but even in the hard brown cataracts, because you know exactly where your rexus margin is. Put the Blurex and keep the Blurex. Sometimes you can put air so that the Blurex stains, the trypan blue stains the anterior capsule uniformly. And once you go around, you can see how I'm trying to do the rexus slightly bigger than the size of the pupil. For me, the size of the rexus matters, and that is very important because when the pupil progressively becomes smaller, you know exactly where your size of the rexus, where your rexus margin is. So in this case, I'm just going ahead and trying to do, because the pupil is fairly mid dilated, and going ahead and doing a trench there. I'm doing what is called a vertical chop. There is no this thing for horizontal chop in this, because horizontal chop, what you do is go underneath with the blunt chop, or underneath the capsular recess, come from the periphery. The vertical chop, use a sharp chopper. You can see here, chopping right in front of the rexus margin. So in small pupils, it's always better when you're using a vertical chop, because you know exactly it's not a blind technique. You visualize each and every step there and go ahead and can see chop it into multiple pieces, making sure that the crack is going all the way into the posterior nuclear plate, which is very, very leathery in these brown black cataracts. So that is again very important. Once you do that, make it into as smaller pieces as possible. Now and then put viscoat into the anterior chamber, and I don't have any financial interest, and but viscoat works very well because yeah, it prevents corneal endothelial damage. You can have clear corneas. You can see how the entire surgery goes on, and you are making sure that you are right there, not near the rexus margin, because I don't want the pupil to, I'm sorry, the iris to come into the port. So you reduce your parameters. Normally, if you are using about 500, use about 300, and if you're using a peristaltic machine, if you're using an aspiration flow rate of about 50 or 60, you reduce it to about 25 or 30, because you don't want that non-target tissues like the iris and the posterior capsule to come forward as well. So just to show you this Maligan ring, the different choices, different things available. Maligan ring is available, the Gupta ring is available, BX ring is available. The only thing is the Maligan ring is like a safety pin. You can see here, it's a there's an injector system. Now the new Maligan ring, the 2.0 version, goes through a very small incision as well. The putting the Maligan ring is not a very major thing, but removing it is really a challenge. You need to be a little careful about that. You can see here beautifully there is there is a dilatation of the pupil. You can see her underlying thing, hard brown cataract, and rexus, making sure that the rexus is as big as possible in a brown cataract like this. As big means you don't want to be more than 5.5 millimeter, or at least 5.25 or something like that, and because you want that space in front of the in the so for you to do the horizontal chop, because these cataracts are very, very big cataracts. They're very large cataracts. The diameter of the cataracts, the thickness of the lens is as big as 5 to 5.5 millimeter, and the nucleus and more nucleus, it's about 8 millimeter or even 10 millimeter for that matter, the diameter. So removing of the Maligan ring is very important. The advantage of the Maligan ring is that the pupil size is maintained very well, and the pupil anatomy is maintained very well. And even in a multifocal lens, you can go to, sometimes iris hooks can damage, you can have sphincter damage. You can see the pupil is exactly round. Or you can put a this thing, or BX ring, which works very well as well. Only thing is, I find the BX ring is a little fragile. So you can go through the main port, you can remove it to the side port. The in a patient with the IFIS, it doesn't push the iris because it's not very resilient like the Maligan ring or the iris hooks. Doesn't push the iris as much back as you want to, and that is one of the major problems with the this thing. But otherwise, it works wonderfully well. You need to have a good pupil of about 5.5 millimeter hexagonal, and that's why it's called BX, and it works very well. Again, a patient, as you can see, a complicated cataract with posterior synechiae and going around, and releasing the synechiae is very important. So once you, because it is a hard brown cataract, you can't manage. Obviously, this video was taken long time back. Once you remove the synechiae all around, you can see here. Sometimes the entire iris is plastered. I'm just doing this iris stretch. The iris stretch sometimes you need to do, and if you don't have access to any of this, but I would not recommend this. But this patient, you can see here, before the advent of the iris hooks or the malignant ring, we are able to manage with this. You can see here, I'm making a deep trench there, and you can do what is called the stop and chop. So once you do the stop and chop, you know exactly, and try to stay always in the center and reduce the parameters as I told you. Again, another patient can see here, this is a floppy iris, a patient. This is a patient on tamsulosin. So these are patients right in the beginning of the surgery. You decide, okay, in the middle, if you want to put an iris hook, it's so difficult. If you want to put a malignant ring, it's so difficult after the capsular excess. So once in the beginning of the surgery itself, you decide, okay, this patient, hard cataract, small pupil, on tamsulosin, the iris, the pupil is going to come down further on you, and definitely if it's going to be 4 millimeter at the beginning, it will be 2 millimeter by the time you are halfway through the surgery. So once you put the iris, you can see how comfortable it is. So that is the main idea. So the visualization is very important. The reason why I tell all my postgraduates and residents is that you need, because you are not good in your microscope, you are not able to focus well, and that is the reason why you are not able to see well, and that's the reason why you are producing all the complications. You should know where your anterior capsule is, you should know where your posterior capsule is, you should know where your zonule or the equator is. And if you want to do that, you need to make sure that the pupil is well dilated as well. So that's again very, very important. You can see how easily it goes off. Yeah, once you remove the nucleus, you can remove one or two iris hooks. But the problem with the iris hooks is that it's really fantastic. It's very easy. Only thing is you need to make 4 ports, but don't keep the iris hooks for too long and have too much of traction. Once you remove the nucleus, you don't have much role for these iris hooks. You can just relax it a little bit, or even remove one or two iris hooks for that matter, because in cortical aspiration, lens implantation, you don't require that much as well. So, size of the pupil is relative surgeon's technique and skill, iris tissue properties, intraoperative situation, and all this. You can see here how I'm trying to do a rhexis beyond the margin of the pupil. How do you do that? You can. It's preferably to use Utrata forceps or a micro Utrata forceps, but you can do with the needle as well. You can go underneath the iris and go all round, and that is very, very important. Okay, and rhexis under the pupillate margin is very important when you are using, and you can sometimes you can get away for the grade 3 cataract, you can get away with pupils like this without any iris expansion. You can by following the protocols which I mentioned. So it's critical when red reflex is insufficient, allows proper, because this is very important. Again, the trypan blue is very important because you need to stain the anterior capsule, because you don't want the what you call the visualization of the to be hampered, of the anterior capsule to be hampered, especially when you are doing the chopping techniques, which is again very important. Adequate hydrodissection and zonal weakness can sink. In chopping technique, I use the karate chop or the anterior chop. Use the cold phaco technology, which is available in all the, there's a micro pulse or the hyper pulse. If you are going to use the Ozil and the Alcon, Centurion, or the Infinity Mission, or the Ellipse on the signature, the J&J mission as well, the signature pro mission. You can see how it's easy for you to go ahead. I'm sorry, yeah. And these are cataracts. The mid dilated pupil you can manage fairly well. Only thing is you need to make sure that your rhexis is slightly larger than the pupil size, and do the anterior chop technique. Use a sharp chopper. The Mohan RAJAN chopper is available with Appasamy. It's a 1.75 millimeter chopper I would recommend for the brown cataracts, and 2 millimeter chopper I recommend for the black cataracts as well. So poor visibility, fibrotic or anterior, fragile anterior capsules, large lens size, adherent cortical capsular connections, thin or deficient epinucleus, tenacious leathery lens fibers, thin posterior capsule. All these are challenges when you have small pupils with hard cataracts. Challenges with small pupils and hard cataracts can be overcome with proper mental preparation. And you need to plan these patients. You have a plan A, plan B, plan C, and you need to talk to the patients adequately, because there can be zonal problem which you don't know because the pupil is not dilating. So this is the, just to give an idea about the small pupils. I would since Sujata, this is actually Sujata's talk, because she is not well. I'm presenting this talk